Improved techniques for schizophrenia treatment. Let's focus on side effects and management of comorbidities. Here are my disclosures. I serve as a consultant to a number of different companies that are involved in the development of the medicines that we're going to be talking about, as well as serving as editor and author of a number of papers that have also talked about this at great length. And I'm going to talk about some things that are not yet available for commercial use, so they are off-label. And some of them include olanzapine samidorphan combination, metformin, liraglutide, orlistat, topiramate, as well as aripiprazole in terms of antipsychotic-related weight gain and so on. We're going to talk about this in some detail that you might not find elsewhere, but every slide is referenced and the activity has been independently reviewed for balance. Our learning objectives is to review the mechanisms of action and risk and safety profiles of new and emerging agents and formulations for the treatment of schizophrenia. And we're going to look towards having choices that are more tolerable and perhaps safer. We're going to explore both the pharmacologic and non-pharmacological tactics and strategies for enhanced treatment adherence, including the successful management of side effects and comorbidities in order to improve the patient's overall quality of life. We'll integrate throughout patient-centered communication methods such as shared decision-making and motivational interviewing. And we're going to talk about real-life situations that you will encounter in your day-to-day practice with people with schizophrenia. So let's start off by meeting Ronald. Ronald is a 21-year-old second-year student at college studying liberal arts. And over the past 6 months, his hygiene has deteriorated. He became more isolative, stopped going to classes. His friends did a well-meaning intervention where Ronald accused them of being controlled by the CIA. Upon evaluation at the Student Health Services, Ronald was diagnosed with acute schizophrenia and given quetiapine. This was his first episode. And Ronald's psychosis was well controlled with quetiapine, 400 milligrams a day. But after about a month or so, he complained bitterly that he was tired throughout the day and he felt like a zombie and didn't want to take the medicine any longer. He was feeling better in terms of, how he thought about the world and getting along with people, but he felt like a zombie. And so the insight into the illness wasn't quite there. Couldn't really make a connection between the quetiapine and feeling better in other ways, and he wanted out of that quetiapine. So there was no point in continuing quetiapine because he wouldn't take it. He was switched to aripiprazole with the idea of eventually convincing him to take the medicine by monthly injection. So we already note that, his insight is not all that great. He didn't tolerate quetiapine. Maybe he'll tolerate aripiprazole, and that comes available in a long-acting injectable, which would be very handy for someone like Ronald. Unfortunately, he continued to feel sedated and at the same time restless. He also gained 20 pounds. So what can we offer Ronald? Well, we can offer different choices that don't lead to sedation, that don't lead to necessarily to weight gain, don't necessarily lead to activation. But our choices are not that many. Now, this is important because with people with schizophrenia or really with any disorder, if they get adverse events, side effects that are really troublesome, they're not going to want to continue taking that medicine. The most commonly associated adverse events with non-adherence, or the events that we typically see in people who complain of not wanting to take their medicine, include weight gain, sedation, akathisia or restlessness, sexual dysfunction, but also Parkinsonian symptoms, tremor, rigidity, cognitive problems. I feel foggy, I can't remember things, I'm more forgetful. But the potential drivers are really the level of distress that the individual has, not generally the severity that we see. It's how they feel about it, how they attribute it to the medicine. And this varies from person to person. One way of looking at it is the side effect, is present. And if the subjective distress is there, that's going to impact adherence. So if they tell you that, my dry mouth is really, very troublesome and I can't take my medicine, it doesn't matter if you think dry mouth is not so important and they should just, live with a mild dry mouth. It's no big deal. To them, it is a big deal. They may also have a delusional interpretation of how they're feeling. So they say that my teeth itch. Now, teeth can't itch, but if they feel their teeth itch because of the medicine, they're not going to want to take it. So subjective distress plays a large role in how the patient will respond. Now, how we will respond, really, we depend a lot on the objective severity that we see in front of us. And we worry when the adverse event looks pretty bad, and patient may not really care. So let's say they gained 30 pounds. Well, we're concerned about a 30-pound weight gain, but the patient is telling us, I feel better. I don't care that I'm 30 pounds heavier. I don't really mind. But we do, and we're worried about ultimately cardiometabolic risk as time goes on. And so that'll influence our response. So we have to find a middle ground here, find something that the patient finds that works well enough, tolerated well enough, they're willing to take, and that we're willing to prescribe. So motivational interviewing, you probably have heard of this before. You may actually practice it. The basic premise is that a patient is ambivalent to change, but that's normal. And they all vary in their readiness to change. But we need to harness this tension to some degree. We need to make them go through a process where they think about alternatives and actually elect to go in one direction or another. When they're the ones making the decision, they're more likely to be adherent to that decision. So let's remember rule. Resist making too many suggestions. Resist being too prescriptive. U is for understanding. We need to understand the patient's motivation. We need to listen with a patient-centered empathic approach. And then lastly, we need to empower the patient. R-U-L-E, rule. Resist, understand, listen, and empower. So with Ronald, we'll need to explore his attitudes about efficacy, what's important to him in terms of what a medication could do, and what his impression is of tolerability issues and what he's experienced, and thoughts about how it may influence whether he wants to take a medicine or not, and being quite explicit about it. It turns out that it's not just about non-adherence, it's also about function. And, Ronald actually explains that, when he feels sedated, he feels like a zombie, he can't function. When he feels nervous and anxious and restless, he can't function. And when he's gained weight, he feels very self-conscious. So many issues here relate to the side effect and its impact on functioning. Now, about 80% of people reported medication side effects in a survey of close to 2,000 people with psychosis. 61% reported impairment in their daily life as a result of medication side effects. And about a third reported moderate or severe impairment in their daily life as a result of medication side effects. And these side effects can be quite disabling and markedly affect quality of life. And if we don't address them early, they'll cause long-term distress and contribute to chronic health complications. Actually, a small shift in functional status may lead to marked effects on quality of life. It doesn't take much. I can relate to that. I was taking a medicine that started to lead to burning sensations in my feet, and I couldn't really walk all that well. That was a small shift in my function, but it had a marked quality of life issue for me, and we had to find a solution for it. Unfortunately, patients with adverse event risk profiles, we know that they have these risk factors, these risk profiles based on their prior experiences, still get treatments that lead to that same risk. Now, what do I mean by that? Well, we all have patients who have a history of drug-induced Parkinsonism, and we continue to give them drugs that are associated with drug-induced Parkinsonism. We took a look at this in a claims database study where we looked at both Medicaid and commercial insurance claims, and we looked at patients who had a prior history of a given adverse event. We did this by noting this in the diagnostic codes or treatments for this adverse event. And then we looked at what medications that they were prescribed subsequently. Well, it turns out that about 80% of those, at risk for drug-induced Parkinsonism still continue to receive drugs that are associated with it. Same with the risk factor or prior experience of or problems with in the history of diabetes, obesity, QT prolongation, hyperprolactinemia, hyperlipidemia, hyperthyroidism, and orthostatic hypotension. All of these things can happen in our patients with schizophrenia. If we look hard enough, we might find documentation regarding these, and yet we still give our patients drugs that may be associated with problems related to the very same risks that they've experienced before. Now, the reason for this primarily is we don't have very many choices. Suboptimal choices are made every day because of the very limited number of options that we have for patients at risk. Here's a table that describes different segments, segment 1, 2, 3, and 4. And these segments represent baskets of adverse events. So there's the cardiovascular basket, so to speak: diabetes, cardiovascular disease, being overweight, orthostatic hypotension, QT prolongation is included in segment 1. Segment 2 includes history of problems related to prolactin elevation. Segment 3 involves a history of problems with excessive sedation. And segment 4, it represents people at higher risk for drug-induced Parkinsonism or akathisia. Now, the middle column represents the proportion of patients with schizophrenia within a segment. And actually, lots of our patients can fall into these buckets: segment 1, segment 2, segment 3, and segment 4. And prior to the availability of brexpiprazole, cariprazine, or lumateperone, we basically had the choices in column number 3 that I call tolerable treatment options. For, let's say, someone in segment 1 who has issues related to being, we have a concern about diabetes, cardiovascular disease, orthostasis, QT, we're going to look at drugs that are kinder and gentler in that department. So we're left with 4 options here: aripiprazole, acenapine, lurasidone, and paliperidone, based on the data that supports their use and their product information, their product label. We say these are, would be a nice fit. Now, again, this is prior to the availability of the newer choices. Prolactin elevation in segment 2, we have 7 options: aripiprazole, acenapine, iloperidone, lurasidone, olanzapine, quetiapine, ziprasidone. Segment 3, the need to avoid excessive sedation, we have 4 options: aripiprazole, iloperidone, paliperidone, ziprasidone. And segment 4, high risk for drug-induced Parkinsonism or akathisia, we actually have only 2 options: iloperidone and quetiapine. So depending on what kinds of things we're worried about, our choices become limited. And they become even more limited when we have multiple co-occurring risk factors going on at the same time. So let's say someone has problems in the cardiovascular department and also concerns about prolactin elevation. Well, there's only 3 choices now: aripiprazole, acenapine, lurasidone. How about patients who need to avoid excessive sedation as well as needing to avoid prolactin elevation? Well, then we have aripiprazole, iloperidone, and ziprasidone. What about patients who need to avoid excessive sedation and need to avoid drug-induced Parkinsonism or akathisia? Well, we only have 1 choice: iloperidone. Now, remember, these choices were before the availability of some of the newer options. So this is a historical perspective to some degree. Now, the last option segment here, or combination of segments, is what if we have someone who has problems in the cardiovascular department, and also we want to avoid drug-induced Parkinsonism or akathisia? Well, in 2015, when I wrote this, we had no options, no good options, and we just did the best we could. Now, why is it? Why do different drugs have different side effect profiles? Well, we do know that receptor binding affinities may have something to do with this, pharmacodynamic factors. We do know that receptor binding affinities has something to do with efficacy. That's why most of the drugs that we have to treat schizophrenia are pretty potent in binding to dopamine D2 receptors. We do know that binding to a variety of receptors can result in side effects, even binding to the D2 receptor. So we know when we have binding to D2, we can produce drug-induced Parkinsonism or akathisia, ultimately tardive dyskinesia in the future, and increase prolactin. We also know that affinity at the alpha-1 adrenergic receptor can result in postural hypotension, dizziness, syncope. It can also be protective towards akathisia, by the way. That's an interesting twist to this story. Alpha-2 adrenergic drugs can lead to increased blood pressure. Histaminergic H1 receptor antagonism can lead to sedation or weight gain. Muscarinic M1 receptor antagonism can lead to memory issues, cognitive impairment, dry mouth. And with muscarinic type 2 through 4, we can have evidence suggesting blurred vision, constipation, urinary retention. Serotonin 5-HT2C antagonism there has been associated with increased appetite. So here we have it. These different drugs that we have different profiles in terms of receptor binding affinities, leading to different propensities to side effects. So here is a summary of some antipsychotics in our wheelhouse. These include some of the newer ones, actually. And here we have both antagonism and partial agonism represented across the board for those receptors that I mentioned a bit earlier. And we see that the Ki, or binding constant, is different and differs from drug to drug. Now, the lower the binding constant, the higher the affinity. So some drugs have higher binding affinity to some of the receptors than others. And each of these drugs are different. And this represents why there's heterogeneity in adverse event profiles for the drugs that we have to prescribe for schizophrenia. Let's take a deeper dive and take a look at the clinical trial data that actually tells us something about efficacy and tolerability from the clinical trials that explains how pharmacodynamics does matter, and the differences in pharmacodynamics may explain what we see in the clinical trials. I like to talk about this meta-analysis from 2013 rather than the more recent ones because the number of drugs is more limited, it's easier to describe, and the principles are basically the same. So 15 antipsychotic drugs were compared across multiple trials in what's called a multiple treatments meta-analysis. This was published in 2013 in The Lancet, and it included a lot of trials. And basically, putting them all together, we can rank order the drugs for efficacy. So we have a list of drugs under the first column, standardized mean difference or effect size in the middle column, and then the forest plot in the third column, the effect size of antipsychotic compared with placebo. Each square represents the effect size, and we can see, how much an effect better than placebo is evident. And the biggest effect was seen with clozapine. And what's interesting here is if we take a look at the 95% credible intervals, think of it as a confidence interval. Those are the horizontal lines that are attached to those squares. We can see that there's a fairly large amount of overlap, except with clozapine. So if we draw a dashed line vertically at the bottom end of the 95% credible interval, we can see how much overlap with clozapine there actually is in terms of efficacy. And there really isn't, except for maybe amisulpride, which we don't have available here in the US. The other drugs don't match up to the efficacy of clozapine. Well, we knew that, and we see that close to it is maybe, olanzapine. Let's take a look at olanzapine and draw a vertical dashed line from the lower end of the 95% credible interval for olanzapine and see what overlaps with olanzapine. Actually, quite a few things does overlap. Risperidone, paliperidone, also zodapine, not available here in the US, but the others generally don't. So this actually tells us a couple of interesting things. One is clozapine is our best drug in terms of efficacy. Olanzapine is second best, but has some close contenders. Now, all this is completely different for tolerability. Let's look at weight gain. There's much more spread amongst the different antipsychotics regarding the effect size regarding weight gain. And if we draw the olanzapine boundary for weight gain, we see that olanzapine is pretty much in a class by itself, that although quite efficacious, is associated with weight gain more so than the other agents, which aren't immune from weight gain, but much less weight gain than we see evident from olanzapine, and a big spread too. So we have some drugs that are, don't look very much associated with weight gain at all. We can see also a different pattern for drug-induced Parkinsonism, or EPS. We'll call that EPS here for our purposes. And haloperidol, of course, is the outlier. Second-generation antipsychotics are better than haloperidol for drug-induced Parkinsonism, but there is some spread regarding this. What about prolactin elevation? Well, here risperidone and paliperidone are the outliers, and they don't even come close to the other drugs with regard to prolactin elevation. Amongst the other drugs, there is some spread. So we see now a pattern emerging that we can talk about. And this pattern is that of heterogeneity for the side effects of antipsychotics. Lastly, I want to mention briefly QT prolongation. Ziprasidone is the outlier here. There is spread there. There are some drugs that are clearly not associated with QT prolongation, no difference from placebo. So we do have some different drugs here. Sedation too, let's not forget about sedation. That's how we started our discussion. Clozapine and chlorpromazine are associated with sedation. They're in a class by itself there. Quetiapine overlaps with them, but the others don't generally. So we have the ability to avoid sedation quite readily. Now, my favorite way of quantifying adverse events is not with the forest plots that I just showed you. That's kind of hard to figure out, okay, what's a real difference? I can see that, our choices are different, but really, can we quantify this a little better so we can understand this more quantitatively? I like to calculate number needed to harm. How many patients need to be treated with one intervention versus another before expecting to encounter one additional outcome that we'd rather avoid? And we can take a look at the clinical trials and compare drug versus placebo. So how many patients would you need to treat with a medication instead of placebo before you would encounter one additional adverse outcome? The smaller the number needed to harm, it takes fewer patients to treat with a medication versus placebo before encountering one additional adverse outcome, and that's a problem. The higher the NNH, the less likely one would encounter that outcome. That's good. I like a high NNH and not have to worry about that adverse outcome. NNH is a measure of clinical significance. It's not a measure of statistical significance. It's not the same as a p-value. It actually tells us something that is going to be important in treatment in terms of effect size. It's an absolute effect size measure. It's not a relative measure. We're not saying something is twice as likely to happen. We're actually answering the question, how many patients does it take before we see an extra case of sedation, for example? It's very easy to calculate. All we need to know are the frequencies of this outcome for drug A and placebo. We'll subtract the frequencies of this adverse event, and then we'll divide by the number 1, or 1 divided by the difference, I should say. So another way of doing it is you take the percentages, you subtract them, and see how many times it goes into the number 100. We'll round up. We do that by convention. So for example, if drug A results in headache 50% of the time, but those who received placebo had a headache 20% of the time, well, we could say that headache occurs 2.5 times more frequently with drug than placebo, but it doesn't answer the question, how often will we encounter it? For that, we need to calculate the number needed to harm. So 50% minus 20% is 30%. 30 goes into the number 100 3.3 times, rounded up to 4. We can say for every 4 persons randomized to drug A instead of placebo, you would encounter 1 additional person with a headache. Well, that's pretty frequent, and I'm going to be concerned about having to deal with headache for drug A. Now, if the number needed to harm was 40, and it would take 40 patients to be randomized to drug A instead of placebo before encountering a headache, I'm not going to be worried about headache. We can take a look at weight gain of at least 7%, the adverse event rates of somnolence and the adverse event rates of akathisia for the short-term trials done in schizophrenia for the first-line, second-generation antipsychotics that we have available. And for the purposes of this table, I've included cariprazine and brexpiprazole. I'll talk about lumateperone, the newest drug, a little later on. This was published in 2016. And basically, we can take a look at the number needed to harm for weight gain, somnolence, and akathisia, and take a look which are the highest numbers. Because the highest numbers mean I'm not going to be as concerned about that outcome for that drug. So let's take a look at weight gain. The highest number here, 67 for lurasidone, means it took 67 patients to be randomized to lurasidone versus placebo before encountering one additional patient with 7% or greater weight gain. That sounds good. How about somnolence? Cariprazine, number needed to harm of 100 before encountering somnolence. Probably won't encounter somnolence with cariprazine. What about akathisia? Well, here we see no ND, meaning no difference. So quetiapine, immediate release, iloperidone, no difference. We'll never see akathisia. Well, never say never. We'll hardly see akathisia. Brexpiprazole 112 and ziprasidone 100. Those sound pretty good. Now, what about the opposite end? What about number needed to harm values less than 10? So in this slide, the circles don't quite match up here. Sorry about that. But let's take a look at olanzapine and quetiapine immediate release for weight gain. And here the number needed to harm values are 6. That's not good. For every 6 patients randomized to those drugs versus placebo, you'll encounter one additional patient who isn't going to have weight gain of at least 7%. That's pretty often. What about somnolence? Olanzapine and quetiapine extended release, number needed to harm of 7. So I'm pretty wary of number needed to harm values less than 10. It means I'll encounter that adverse event more frequently. Now, let me give you a caveat as we're winding down. Antipsychotic-related weight gain can occur with all antipsychotics. It's more pronounced when antipsychotic naive patients, can occur over time, not clearly dose dependent. The weight gain, the risk is polygenic, associated with variants that we see in our patients, but we don't have an ability to measure. We know that these genes coding for antipsychotic pharmacodynamic targets may play a role here. But there are some differences that we can quantify, as we just did. But the bottom line is your individual mileage may vary, and I weigh all my patients every time I see them in my day-to-day clinical practice. Some hints I can give you regarding olanzapine. There seems to be a pattern. Patients with a higher baseline BMI gain less weight. The effective dose doesn't seem to be so relevant. The weight gain appears to be at the beginning and then kind of plateaus, although that is controversial. We do know that people who gain weight early, though, and gain a lot of weight early, are going to be at higher risk for gaining weight long term. So I'm wary about those early weight gainers. We saw this in studies in schizophrenia, and we also see it in studies of bipolar mania. And a rule of thumb is, if someone has gained 2 or 3 kilos within the first 3 weeks of treatment, let's say 2 kilos by week 2, 3 kilos by week 3, they're at high risk for substantial weight gain as the weeks accumulate. What can we do with antipsychotic-associated weight gain? Well, we can do non-pharmacologic interventions. They work. So nutritional interventions and cognitive behavioral therapy, if patients can successfully participate in them, have shown some benefit in outpatient trials. We can also use pharmacotherapeutic interventions, metformin, for example. Meta-analyses there tell us that it works. There is some degree of nausea and vomiting and diarrhea that we need to manage, but otherwise no difference is found in adverse effects. And we saw significant, in this meta-analysis, significant superiority to placebo in terms of the outcomes of body weight, BMI, glucose, insulin, triglycerides, and cholesterol. Adjunctive metformin can be administered in an effective and safe manner and is a reasonable choice. Using it early seems to make the most sense for preventing the initial weight gain in people at high risk. And the advice is to give it early on, and particularly important for young, healthy patients who receive olanzapine or clozapine. When combined with diet and lifestyle changes, the effects appear more pronounced. So we start with 500 milligrams twice a day or 850 once a day with meals, increase it in increments of 500 milligrams weekly or 850 milligrams every 2 weeks, up to 2 grams a day given in divided doses. But we need to use it safely. And GI adverse events are common, and that's why we'll do the gradual dose up titration. Lactic acidosis is actually quite rare, but we will check creatinine levels annually. We'll also need to assess serum B12 levels annually, since metformin can impair vitamin B12 absorption. So that's an option we have today. Other options that have been studied include liraglutide, a GLP-1 receptor agonist. Short term look pretty good, longer term not as good. It is quite pricey. I'm not sure where this is headed. Orlistat added to clozapine or olanzapine did not show efficacy. Topiramate did show some efficacy in terms of weight loss, and it may also be helpful in decreasing symptoms of schizophrenia, but can impair cognition and difficult to tolerate at the doses we need to give. Now, adding aripiprazole to clozapine or olanzapine may be another option for weight loss, and there's research that's published, pretty good research that supports that. In the pipeline is a combination product. I call this slide, Let's Make Olanzapine Great Again. And this looks at an intervention that combines olanzapine with samidorphan. Samidorphan binds to a variety of opioid receptors. And in the end, we have mitigation of olanzapine-induced weight gain. So basically, we still have weight gain, but it's not as much as olanzapine plus placebo. And we see this in the study comparing olanzapine plus placebo versus olanzapine plus samidorphan. The amount of weight gain is less. And this may be an opportunity to use if approved by the FDA. Now, the new kid on the block, lumateperone, is an interesting antipsychotic. It's an atypical indicator for the treatment of schizophrenia in adults. Recommended dose is 42 milligrams once daily with food, no titration. It's one dose only. The binding affinities for lumateperone are interesting, primarily serotonin 5-HT2A, much more than dopamine D2. The Ki values is very different. And so we would say this is a serotonin 5-HT2A antagonist primarily, with some binding affinity to dopamine D2. Also binds to the serotonin transporter with the same affinity as to D2, by the way. Has some affinity to D1, and basically not much affinity to muscarinic or histaminergic receptors. There was no difference from placebo noted in weight gain of at least 7% from baseline, so that's very good news. There was no drug-induced Parkinsonism, including akathisia, compared to placebo. The rates were 6.7% versus 6.3%, so the number needed to harm of 250 is so high that, I'm not going to really expect to see this. However, somnolence or sedation was higher than that for placebo. 24% for those randomized to lumateperone, 10% for those randomized to placebo. 24 minus 10 is 14. That goes into 100. Round it. Number needed to harm is 8. For every 8 patients randomized to lumateperone versus placebo, you expect 1 additional patient with a complaint of somnolence or sedation. Now, mind you, these trials were done with the administration of the drug in the morning, so I would administer it in the evening with food and hopefully mitigate against that. But it's another option. Now, treatment is a dynamic process. We have lots of choices, lots of opportunity and risk here. We ask ourselves, is our choice going to relieve the symptoms well enough? And for patients like Ronald at the beginning, is it going to be tolerated well enough so that the patient's willing to take it? We want to get the patient to buy in order to promote adherence. Now, patients have their own preferences and values regarding what's important to them in terms of symptom control and what's important to them and what tolerability issues they're willing to live with or not. I didn't mention long-acting injectables, but that's also an important consideration, particularly with adherence. And, I want to give you some tips here before we end about how we can communicate better with our patients and put ourselves in their shoes and help them make a decision that's wise for them. So I have my standard lines here for LAIs and adherence. You can adopt them for really talking about all sorts of things about psychotropic agents. I have high blood pressure and take pills for that, and sometimes I forget. How often does that happen to you? Get some thinking about missing a medicine is not so strange and unusual, and that it happens to everyone. How would you like to get your medicine once a month instead of a pill every day? I know I would. It must be hard to hear your mother constantly ask if you've taken your medicine every day, day in, day out. It must be hard to remember if you have taken your medicine last night. This is different from when you were in the emergency room and got a shot. So let me describe this to you. Would you like to give it a try? If you don't want to take it again, you don't have to. So these are some of the strategies I use. They can be adapted for a variety of needs. Switch or stay is not an easy decision. We need to take into account the past history of efficacy of drug response, the nature of their psychiatric condition and their acuity, target signs and symptoms, their preferences and history of adherence, any need for special monitoring, and their amenability to other interventions to address the tolerability issues they may experience. Can they go on a diet, participate in a diet, do exercise, take statins, take a beta blocker? I don't like prescribing anticholinergic medicines, but sometimes we need to do that for drug-induced Parkinsonism. That's a whole discussion in itself. So we need to see if we can give other drugs to treat the adverse events, but I'd rather avoid them in the first place. Let me finish off by giving you the updated treatment options for patients with multiple commonly co-occurring risk factor segments. We talked about this a little while ago. Now we have new treatment options. We have brexpiprazole, cariprazine, lumateperone, and they fit in nicely for choices for combination of segments. And now we have potential choices, actually, if we dig down and look at the choices for those who have problems with in the cardiovascular department, or also need to avoid drug-induced Parkinsonism and akathisia. Well, we have brexpiprazole or lumateperone now to consider, whereas before we did not have any options. So this is interesting. New drugs are important to us, and hopefully one day we'll have a drug that eliminates all these segments from consideration, and we can prescribe it without concern about cardiometabolic risk, prolactin elevation, sedation, akathisia, or drug-induced Parkinsonism. Well, that's what I hope for the future, and as drug development continues, we can look forward to that. This brings us to the end of the presentation. Thank you so much for your attention.